and stares in our window, blocking out all we can see. We ask ourselves the same old question: who will be there for me?
Hey, this is Daryl Pillsbury along with Richard Davis, right here. There he is. Hey, Richard. And we're here again for another healthcare update, and we got a lot to talk about, so we're going to get right to it. We had a bill passed, and we're going to talk a little bit about what's in it and what's not, and where do we go from here. So, Richard, Governor someone's going to be signing the bill. Are you going up?
Oh, yeah.
Bill signing?
I'm going up, actually. The bill's going to be signed on May 26th, so this may be before and after this program airs, but on May 26th, and they're actually going to do it in the well of the State
Actually,
House.
what we're going to say today will happen before May 26th,
Okay.
Unless you're responsible for the editing.
No, we'll get it done. So anyway, May 26th, 10 a.m. in the well of the House, and they want a lot of people to show up because, you know, they want to make a big event out of it.
It's probably national.
It's important. So anyway, that's the bill's going to get signed, and then what happens? So.
Well,
okay.
Let's talk about some of the, let's start right from, I'm kind of going down with your article, which people can, well, you won't be, it's going to be in tomorrow's paper. But unfortunately, you've either already read it or you threw the paper away by the time you get this. Let's go with the principles first.
Well,
okay, the principles guiding the reform effort.
Well, I didn't delineate them, but the principles are that, you know, they're very broad principles, that it should be fair and equitable, but some of the other principles are that people should be able to choose their health care provider, that providers should be reimbursed at an adequate level, which means, you know, not the way they're reimbursed now, where the system we have now,
Can we not call it a system?
The non-system that we don't have makes providers subsidize the care. Every time they need to save money, they just cut back on how much they pay the providers, which that doesn't work. No. It's not going to keep working.
No,
so,
and we're having a hard enough time getting primary physicians in the state now where it's going to be harder and harder all the time.
So that doesn't work. I mean, a lot of these principles are basically what Senator Kevin Mullen had put into the bill. You know, they're vague and broad, but they're important. So
it was important to get him to sign too, so he wanted those in there.
Even though he was the only Republican in both chambers that voted for the bill, the only one.
Yeah, that tells you something right there. We're so far apart, Richard. This blue-red thing. Watch my next rant, okay? Right now we're talking health care because I got a thing about the two-party system.
All right,
I'm telling
take it easy, Daryl.
Yeah. Anyway, I tell you, it just kills me. And this is one of the reasons why we're not getting anywhere, though. Come on, listen to these people, for crying out loud. It's
all right, I'm going to check Daryl's blood pressure. We're going to see what kind of effect
it's awful. It's through the roof. Every time I go, man, the doc says, you got to do something. I go, yeah, the only thing I can do is sleep. Catch it when I first wake up.
Oh.
Okay, I'm pretty good when I first wake up.
That doesn't count.
And then once the day starts, it kind of, you know, starts getting to me.
It's not good for you. So anyway,
okay, one of the first stages will be to set up the health benefit exchange. Talk a little bit about that.
All right. This is sort of a complex issue, but we'll make it simple.
Do the best you can.
We'll make it simple. The federal health care bill requires all the states by 2014 to have what they call health care exchanges. And really, all it is it's a marketplace. So essentially, it's just going to be a website location, and there'll probably be a real one too.
And is it supposed to show like competitors' prices and things like that?
Well, there has to be a minimum. A state has to have a minimum of 2 health insurers, and this exchange has to show, and this is what in clear English that the average person can understand, what the benefits are and how much they'll cost. Okay, so Vermont will have at least 2 plans available. So that's what this does, is really just put the language of what is required of us in the bill for the exchange. It's not anything beyond that. However, we have to keep in mind that, and this is what the governor wants, and there's a provision in the bill that allows us to go beyond this exchange. And really, because this isn't really a single-payer bill, it just sort of tries to get us there.
Yeah.
This is probably the most critical element, because what we're going to ask for is a waiver on the exchange. And what that waiver will say is Vermont wants to just put one insurance plan in the pool, and they want it to be administered by the state and not a private insurance company, but the private insurance company could be the administrator. So that's the next step after the exchange, and that would make it, not completely, but that would head us
No,
really
and if
closer
that-
to single payer.
If that step isn't successful, is the whole process done?
Well, no, there's ways around it. You know, there are other ways, but that will make it really difficult. On the other hand, it doesn't stop the state from putting their own plan in there, as far as I understand. They can put their own plan in there, and if it's cheaper and better than the other plans, then they can use the marketplace forces to create the single payer because it's a better option, and then more of the people will migrate and buy that. So that's the second best possibility. That it could play out that way, as far as I understand it.
Okay, well, hey, you know, there's still a long way to go, and that's one of the things I think people are confused because, you know, out there everybody's going, oh, this great health care bill. When is it going to affect
Right.
me? And I tell everybody, wait a minute. Don't expect you to all of a sudden there's going to be a health care package for you because this is the blueprint. This is the roadmap to get us to where we hope to
Right,
get.
yeah, and one thing to point out is, you know, that's a good point, is that most of the time when we do legislation on public issues, social issues, we don't make a point of having a public discussion or a big debate or in the news before all the ducks are in a row and before it's actually accomplished. But this is unusual in that we're talking about this and making this a public issue before it's even
I think, though, that might be a better way to go,
I think
Richard, because now hopefully we'll have everything hashed out. I mean, you won't, but hopefully we will when we get this thing rolling, and it will be a little bit smoother process. That's what I'm hoping for. And I think by doing this, it ups our chances of being successful, though.
Well, I agree, and it makes the process a public process where people at least have the opportunity to be engaged. You know, the usual 5%. It'll probably never be more than that, but even that. So this has created an incredible stir throughout the state of Vermont and across the country because we've made this a very public process. But on the other hand, back to the original point, is people are impatient. It's like, well, what am I going to get out of this anytime soon? And the answer is zero, because the earliest time that anybody will actually see anything is 2014, and that's when
2014. Well, that's a little earlier than I thought.
No, in 2014, these exchanges will be up and running. So the hope is that people have better insurance options by then.
Yeah.
That's the first step. And that's not great, but, you know, that's the beginning. And then only certain employers can buy in depending on the size. But 2014, there'll be some changes, but not for everybody, for some people.
All right. One of the things that I do like about this bill, because when I've talked to a lot of people, especially nurses, because we got a lot of traveling nurses that come from other countries, they always say, wow, one of the problems you got here is the malpractice insurance here. Now, personally, it's a tough issue for me because I think if somebody makes a major mistake, you should be compensated. And we're not saying you're not going to be, but there is some proposals in it to reform malpractice. Do you know a little bit about that?
Yeah, well, what they're going to do is they're requiring the Director of Healthcare Reform and I believe the Green Mountain Care Board, one of those or both, they have to present, actually by, I think it's January 1st of 2012, almost positive, they have to present a plan and a study for implementing a better malpractice reform for Vermont. And what that boils down to, just so, you know, let's make it a little bit clearer. So the actual numbers in terms of people who sue and the amount of money, it's estimated to be about 1 or 2% of the overall healthcare budget. So it isn't, we're not talking about a lot of money, but there's other issues that are related that are probably even more important than the overall, you know, adjudication process in the court system, is that because of the system we have, doctors are forced to practice defensive medicine, so they order more tests than they may normally order, and they do a lot of extra things that may not be necessary because they're afraid to get sued. They don't want to get sued. The other issue that is really significant is the amount of money that doctors have to pay for malpractice insurance. So, for example, it's not uncommon for, you know, the higher risk doctors like orthopedic surgeons and OBGYN and neurosurgeons to pay $100,000 or more a year just for malpractice insurance. So if we have a system that puts a cap on malpractice awards, it should change those other things down the road, you know, in terms of defensive medicine, in terms of the amount of money that doctors have to pay. I think there's also a really good model that exists in a lot of European countries, and especially Scandinavian countries, what they call no-fault malpractice, which means...
kind of like the no-fault car insurance?
Well, it's sort of, but you can't really, you can sue, but the doctor has to disclose, they're required to disclose immediately anything that went wrong. It forces them to do that, which doesn't always happen here. But what other countries have found, and even studies done in this country, is that if a doctor messes up, whether it's intentional or not, which is usually just an accident, if they immediately tell the person what happened, most people won't sue. All they want is an accounting, and they want you to be honest.
Yeah, I think...
But when doctors aren't straightforward, those are the ones that get sued. Because I could give you examples, even from this community, of doctors that should be sued.
I could too.
You know, but they're nice people and they're honest. And when you do that, people don't want to sue you if you're up front with them, because they realize you make mistakes. I mean, if something's really horrible, these systems in Europe set aside enough money to compensate people if something really bad happens, but they take away the whole incentive for practicing defensive medicine. And the other thing is, then doctors don't have to carry malpractice insurance, or if they do, it's very minimal, I think. So anyway, that's that issue.
So listen, you've talked about the Green Mountain Care Board. I don't know if a lot of people, even I'm still a little confused on that, exactly what it is. Can you talk a little bit about what, because that's going to be playing a big part in this.
Huge, huge.
So what is that exactly? Explain the Green Mountain Board and their role.
Okay, so what this new bill or the new law will require is that there'll be a 5-member board called the Green Mountain Care Board. Now, Green Mountain Care is the name of the new health insurance plan that we will supposedly have sometime soon. So the plan doesn't exist, so we have to keep that in mind. That's something down the road. But in order for the plan to come into existence, the board will have a chair and 4 other members, and they'll be serving rotating terms for a number of years. They will be nominated by the governor, but initially people felt that that was too political. So what they did is they changed the bill, and now there's a nominating committee. So people will submit their job application basically to this nominating committee.
Because this will be a full-time job. I was even confused on that when we were talking.
No, this is definitely
this is a job. This is not one of them committees I can get appointed to.
No, you become, in the language of the bill says you become an exempt state employee.
Yeah.
So it's good because they'll get benefits and all, nice health insurance.
Yeah, we're getting rid of employees though, but that's okay.
So anyway,
this is
important. So they will be, first of all, have to apply to this nominating committee. The nominating committee will screen the applications, send what they believe the best candidates are to the governor, who will then appoint the members. There will also be an advisory panel of experts to work with the Green Mountain Care Board, and there will also be...
Oh, I just found your job.
Yeah. No, but anyway...
That's where they'll do to you, though.
And then there'll be... the other level of this is that there'll be... I forgot what I was going to say.
Oh, I'm sorry.
So, well, wait a second. So there's the advisory group.
And the nominating committee.
Nominating committee. And there's one other... Oh, I know what I was going to say. The bill provides for some staff people to be moved over from one of the departments to
staff it.
Yeah. Well, actually, now, this reminds me, it's not related to any of this, but it's important. I just got a news flash. You hear it here?
Good. Here it is. You're hearing it right here.
Yeah, but unfortunately, it'll be a lag. I just got a copy of a letter from Susan Basayo, who runs over. She quit.
Yeah. She did?
Yeah.
Wow.
Yeah, big news.
Because I sit on I sit on, if she's still on
She's
it.
going to become a consultant.
Really?
Anyway, we
need to make some
just
money
thought
now.
I'd make a news flash here.
Yeah.
Anyway, okay, so back to the Green Mountain Care Board. So this board has been charged with a number of things to do. First of all, and they're not going to once they do something, it's not absolute because it's going to have to run by the governor and the legislature. There's going to, it's,
Oh, yeah,
even though people think they have too much power, they're not going to be able to do any of this without approval from the legislature. And most of this is going to require legislation. They're just going to recommend. So what are they going to do? They're going to develop the benefits package. They're going to develop the financing plan. They're going to develop all the mechanisms that need to be in place for this Green Mountain Care plan to work.
Wow, that's 5 people with a lot
Wait, there's
of
even
power.
more power. This is where it gets interesting. Now, up until now, for the past 10 or 15
They
or 20
better
years...
have a lot of knowledge too, Richard.
Well, they should. So, for the past decade or more, I don't know how long, there's something called the Public Oversight Commission that has... And they have been they've been an arm of the Banking and Insurance Healthcare Administration. And their job has been to approve hospital budgets and certificates of need, or at least make recommendations for those. They will no longer exist. Their duties will be taken over by the Green Mountain Care Board.
Really?
So the Green Mountain Care Board, in addition to the duties I just outlined, will also be in charge of hospital budgets and the certificate of need process. But there's also a new position created called the Director of Healthcare Reform, which it's not clear how that's going to play out because there's already a sort of a director in the Healthcare Commission. Now, the healthcare, this is all bureaucratic double type, but the Healthcare Commission is going to go away too, so that won't exist anymore. And there's already a director in that office, so it could be the same person that takes that over. Who knows? So,
who's the director in that office now, Richard?
Her name is Catherine Benham.
Okay.
She took over when Jim Hester quit to go take a job in Washington, but he knew the job wasn't going to exist anymore. So anyway, and also what people seem to be talking about behind the scenes is that there may be once all this stuff plays out, when the bill is in place and they're actually doing all the appointments and everything, there probably will be some kind of streamlining in the Banking, Insurance, and Healthcare Administration. And some people will come over to work just with the board, you know, and they'll eliminate some positions. So a lot of people close to the Shumlin administration are talking about sort of a realignment of all the bureaucracies. So that would be a good thing, maybe cut out some jobs, move people where they can do more. We'll see how that plays out.
Hopefully that works out. I haven't been really, I know our state workers are working hard and a lot of cuts and stuff, but I got to tell you, I've had a few friends that have been dealing with the state on a variety of issues, and it hasn't been going very well for them, I'll tell you that. And it seems like we've got an awful lot of incompetent things happening.
Oh, wait,
it's really starting to bum me out, folks, and I'm a working class stiff, and I support other working class stiff, but man, you guys working for the state, I don't know what the problem is, but you better start.
Oh, well, here's another one.
It's really been awful.
Some more fuel. I can't remember the exact details, but I got a memo from one of my insider people a week or two ago. It was unbelievable, but it turned out, it was either VHAP or Catamount. Somebody had looked over the books and found out that they had overcharged people for premiums for like a year and a half or something.
Wonder where that money went.
And they have to give it all back.
To the people.
Yeah, which isn't a lot. It's going to amount to
and I'm sure most of those people, they're on VHAP.
Yeah,
they can all probably use a $20 check.
Yeah, so anyway.
But there goes another little
happen.
budget. Yeah, it does. Yeah, at least it's only $20.
Yeah, it's not a lot, but you know, it's like you say, it's significant for people that are struggling to pay.
Oh yeah, hey, I'd take a $20 right now myself. Jeez, I'm crow. Just so I could put gas in and I could actually drive out of town.
You wouldn't get very far at $20.
I'm telling you,
that's
incredible for me either. I can't believe they're not considered terrorists. Yeah. That's another rant.
Oh yeah, let's get going.
So listen, here's another one there. And this is I got most of what I'm talking about here out of your article, so people, you know, and we're going a little more in depth in the article, but. The Green Mountain Care benefits will provide at least 87% of the full actual value.
Yeah.
Okay, in plain English, that means that a policyholder would have to pay, you know, only 13% of the costs above the 87%.
Yeah. In other words,
if it's $100 and they will pay 87 of it, you're responsible for 13.
Basically. Okay. So, what actuarial value means in the double talk is that what are you on the hook for? So, and that 87% includes the premium, no matter who pays it, from what I understand. So you could still be paying, you know, 20% of the premium and your employer 80%, but then that other 13%, is copays and deductibles.
Right.
So that it's basically it's out-of-pocket expenses beyond the premium. So it's sort of like it's ridiculous in a way, but it's good to know what the numbers are. So
Well,
they're
you got to
designating.
know.
they're saying that if you put a policy in place, no more than 13%. But there's another figure that's more important, and this is sort of a national figure that most people have agreed on, is that if you're spending, including the premium and all these other costs, copay, deductible, if you're spending more than 10% of your income on those things, that's too much.
Yeah.
It should be below 10% or below. Even 10%'s a lot. I mean, I'm spending like 20% or something. But anyway,
I'm up there.
So if it's more than 10%, that's a hardship for the average American. So
I totally would believe that.
But
now, this is the thing, though, is the 87%. So part of the Green Mountain Care board is going to have to. Are we going to have fixed prices?
Fixed prices.
Well, I mean, you can go to a doctor, you can go to this hospital, that hospital, this hospital, that hospital, get the same damn thing done, and everything's charged differently.
Well, actually, one of the provisions in the bill talks about rate setting.
Yeah, okay.
So,
see, I'm for that.
But it doesn't say, it's not specific, so it just says, well, they'll have responsibility for provider rate setting. So one could say, they could go around.
We charge different rates right at the hospital for the same damn thing, depending on what you got for insurance and stuff.
Well, here's
I mean, come on.
Well, here's the way it could play out. Let me explain it, because that's a good point. So, say that I'll give you an example of something that varies incredibly around this: colonoscopy. You could spend $2,500 in Brattleboro and $4,000 in Fletcher Allen for the same procedure. Not any better or any worse. So, how do you control that? Well, here's how it would work: is let's say that the state, or let's say the Green Mountain Care Board said rate setting, and they said, okay, we're going to reimburse $3,000 for colonoscopies no matter who does it. Well, it's not clear too, because then there's a doctor's fee and all this other stuff. But let's say just for the base, let's say the package or whatever it is. Okay, so it's $3,000. Well, then Fletcher Allen's going to complain, oh, well, we have a bigger hospital and we have to pay people more, and BMH is going to they might make money on it, and they're going to say, oh, that's wonderful. So how do you deal with that? Well, the next step deals with that is that if we get to the point where we have global budgets, which means hospitals will be given X amount of money based on how many patients they have, or how many, and they have to live within the budget, then whatever they get reimbursed for that procedure could be offset by the global budget, because then when they calculate, if you follow me, they calculate the budget, they'll calculate some of their loss of the
that's counted in it.
So that might be a way to offset it. So there's a case for global budgeting. It's not quite that simple. It's not a give and take like that, but you could look at it that way. So, but I think it would be tremendous, just from the consumer point of view, to know that whatever you have done, say a total knee replacement, there wouldn't be a $2,000 variation from one hospital.
Yeah, that another thing that I don't know if they're going to do, and I don't know how you can do, but one of the things compared to Canada and here, people all say, you got to wait so long in Canada. Well, one of the reasons you wait a little longer in Canada is because, like MRI machines, Orange County, California, and I always say this one because this is one stat I always know, Orange County, California alone has more MRI machines than Canada. Okay, so what I'm wondering if these guys are also, because the first thing that happened when we put our MRI machine in hospital, what's the first thing you had to do? Well, you got to start using it.
Right, you got to get people in
Which
there.
means I'm not sure about this or not, but if you got to use it, that means I'm not sure if people are actually getting it done that don't need to have it done. So I mean,
that's a no-brainer.
But that's a problem.
Well,
you got to pay for the thing. Yeah, but no, I want to get you going on. Well, we got only a couple minutes.
I just want to make a point on this too, because you have the certificate of need process that's been in place for years.
Yep.
And so, say for example, BMH needs a CO and a certificate of need to put in an MRI, right? Part of the process says they will only do so many exams per year.
Yeah.
Okay? But they never stick to it, and there's no enforcement. So it doesn't, I've seen this happen. It happened when the CT scan went in. Oh, they're only going to do this many. Give me a break.
There's another one of those things. We were only going to do them on Mondays or Tuesdays, whatever day it was,
Right.
and I'd set it all up to do it. And but then the problem was there were so many that had to be done.
Right.
You couldn't meet the Monday date, so then it became Monday, Tuesday. Then it became Monday, Tuesday, Thursday,
Right.
Friday. I mean, it's like if you got it, you're going to use it, which drives up the cost of health care.
Right, and it's not like other things that go down. If you historically went back and looked at when Brattleboro got its CT scanner way back, and looked at the number of exams it was supposed to do and how many it's done, I think it would blow you away.
Don't worry, I worked there. It does blow me away.
And the other thing, this is really interesting. We're lucky in Vermont. I don't know if there's any yet, but you know, where these doctors who own the clinics, they just have standalone MRIs.
Yeah.
So they're not prescribing anything to do.
Yeah. No, and that's something that I hope we take a better care.
Well, we're Vermont's
Listen,
good.
one little stat here. We got to get ready to close it down and leave.
4 minutes.
In Canada, they just had they just did a poll of all the folks there because you know I always hear how the Canadian system stinks. Depending on who you're talking to, of course.
Right. Healthy people.
But they just had who was
I know the most. This was a while ago.
who
The
was
biggest hero.
the biggest hero
Tommy
in
Douglas.
that country. Tommy Douglas. I know a lot of you don't know that name, but you know what he did?
He beat out Wayne Gretzky in the poll.
That's saying something,
Yeah.
okay?
Yeah.
But nobody knows what he is.
Oh, you can tell.
Who is he?
Oh, he's the father of their healthcare system.
That's right.
Yeah.
He's the guy who designed this thing, came up with it in the 40s or 50s, or when the hell did he do it?
Well, it was implemented in '65, but
Okay.
it started a little before that.
But he is the guy, and that just goes to show you. And if you actually look at the poll, see when you argue with me about this and the Canadian system and something else, please come to me with something other than you heard something, okay? Because I read a lot more on what's going on up there, and their polls don't lie. The people up there prefer their system. They can't believe what we got here. So, you know, and it just blows my mind how many people use them against us. It's just silly.
Well, the other one.
And I'm sure you got a few cases up there from Canadians that are going to tell you it's
Well,
stunk.
you're
But you're going to
always
get a
gonna-
billion of them down
You're
here.
always going to have that.
Talk to my guy.
Well, ask Canadians what their biggest fear is if they go on an extended vacation in the United States.
Yeah.
Their
Getting
biggest
hurt.
fear is getting hurt.
Yeah.
So
and,
what they
and
have.
how many bankruptcies they have in Canada due to health care? Zippo.
Yeah, but-
We're in the 600, 800,000 a year.
But they have this.
Bankruptcies.
But what you can do is if you go across
But
the
our
border
system's really good.
from Windsor, Ontario to Detroit, Michigan, I'm not sure which side of the border you buy this on. Canadians invariably they'll buy a month-long insurance policy
Just
from
some
Canada,
will,
like
some
a
won't.
special add-on.
$5,000 more to build a car here in Vermont.
You know,
I mean, in this country.
Don't
than
break
over
your
there.
arm in the United States while you're on vacation because it'll cost you too much money.
It's unreal. Well, Richard, again, thanks for coming. Some good information there. We'll keep the folks around here informed.
We have
as
been,
always.
as always.
And our next thing is where do we go from here? Which we don't have time for that. We'll have to
We'll find
talk
out where
about
to
that
go.
on the next show.
Next show, where do we go?
So anyway, tell everybody goodbye now. This is
Goodbye
where you get
now.
to say goodbye.
Goodbye now.
Okay. This is Daryl Pillsbury along with Richard Davis. This has been another edition of the Healthcare Update for my cameraman, Joe.
Hey, Joe.
Yeah, Joe's waving if you
All
can't
right,
see him,
Joe.
but believe
I can
me, he's
see him.
waving.
I see him.
We hope you enjoyed this. We hope you're getting some good information. We'll see you next time right here on the Healthcare Update.